So if we could start, and if you could just say who you are and why you're here, that'd be nice.
So I'm Derek Alderson. I'm currently the President of the Royal College of Surgeons of England. I still hold an emeritus chair in surgery at the University of Birmingham, where I was the head of the academic department for 10 years. Before that, I was Professor of Surgery in Bristol. I worked there for 17 years. And my own area of clinical interest was in esophageal and gastric surgery, mainly esophageal and gastric cancer, although I did do a lot of hernia surgery in my earlier years and certainly in my training, and was involved in some types of mesh-related, minimally invasive laparoscopic surgery in the later parts of my career.
Right. Well, thank you very much for that. I just wondered if you could say a little bit about your colleagues in the profession and how you think these operations have been performed, and really whether you feel there's been in the past enough skills, enough education, enough knowledge on how to insert mesh into the areas that we're looking, which is the pelvis.
So it's difficult for me to comment, of course, on behalf of the community of gynecological surgeons, because they are a separate college and they have a separate training pathway from surgery in general. There has been a separate college for some time. And obviously many of the meshes that have given rise to concern are related to gynecological practice and uterine prolapse. The urological surgeons, of course, have inserted tapes and meshes for urinary incontinence, and they, of course, are members of our college. And I've spoken to the urologist about this. Clearly, there has been training of urological surgeons for a substantial length of time. Whether or not we believe that the methods by which we train surgeons in new technologies is fit for purpose in the future, I think is something that definitely needs to be visited and examined very carefully. What happened in the past, it of course reflects the way in which surgery was being taught, let's say in the 1990s, and things have evolved since then. So it may have been acceptable in its time, but I would say that that methodology is no longer acceptable for the introduction of a new technique, a new technology, or whatever it happens to be now in the 21st century.
Yes, well, thank you. I mean, we know how medicine, how surgery, and all the related professions and things keep changing, because I believe that the Royal College, your college, has produced a very interesting paper on the future and how you see robotics and various other things being introduced. So obviously we are going to go forward, but we also have to look back a bit about what's happened, why it happened, could it have been avoided, should it have been avoided, and so on. But you wrote a very interesting article, Innovation and Enthusiasm, and there is a very charming photograph of you at the top.
I was a lot younger.
And you also say that new developments obviously need to be designed to improve patient outcomes, and you need better research, innovation, and quality improvements as a continuum. And I'm just wondering where you feel in the past this sort of thing was not addressed.
Okay, so I would say that whether we're talking about implants, mesh, whether we're talking about the use of new technologies, robotic surgery or keyhole surgery, or whether or not we're talking about the use of novel devices in the context of that new type of surgery. So implants, devices, and new technologies. The big mistake, I believe, is that we did not have compulsory registration of devices and technologies by the time they reached the clinical workplace and started to be used in patients, let's say beyond preliminary trials, etc. Even that, I think that, I mean, obviously they might be done in the context of research studies, so there is a type of registration that might be there. But discarding that very small number of patients at the beginning of it, I think that we definitely have failed patients by not having compulsory registration for these devices.
Perhaps do you want to come back to that?
If we can just explore that now, because it's if you raised it. My experience with registries was with the European Alderson Transplant Association register. And every child who in Europe had a kidney transplant was automatically registered there and then it had taken place. The registry was more complicated because then you went back and asked very specific questions about outcomes and the whole range of outcomes, not just clinical, but effect on the family and so forth. That required an input of resource to do that.
Yes.
It was something I could fill in any more than you could fill in if you'd done an operation. So we've been interested in the notion that the first thing that needs to happen, picking up your point and what you say in the future of surgery, which I think is first rate, if I may say so, is you need to register the fact this operation has taken place.
Correct.
And it has been done by Professor Alderson. He's done it on Cyril Chandler, and he was suffering from this, and this is just the operation note, and this is what you did.
Yes.
And you barcode what you put into me,
Yes.
and it goes on a national central database, and it could be done at the same time as you fill in the operation note.
Absolutely. Yes, I agree 100% with that. And of course, it's the next step that's the critical one. In other words, I'm sorry, you have heard this 1,000 times, I'm sure, and I'm not trying to oversimplify. A registry of its own right does not create patient safety. It's just a list. The registry must contain information that can be audited. So the next bit of the puzzle is the bit that costs a lot of time and a fair bit of money. The registration process, I agree, should be relatively simple. You should be able to do it at the time that you put the implant in or use the new technology to do the new operation. Correct. Held by a responsible body. It could be a professional association. But the registry simply allows you to carry out a high quality audit. So of course you might say the items that you want to collect in the registry should be items that you are reasonably confident would be worthwhile auditing down the line. So if it's a new implant, I want to know were there any short-term complications related to its implantation. And of course, in turn, high quality, well-conducted audits lead you to be able to ask sensible research questions that bring the thing kind of full circle, and you set up to do a proper research study to answer the next thing, which has been highlighted by the audit. So if we were to take just any imaginary mesh, we would register the use of those meshes in whatever group of patients it is. We collect information, we see whether or not there are certain complications that we perhaps did not anticipate, and we then think, okay, how do I now devise a research study to tell me how do I get rid of these complications, or how do I minimize the risk of these complications.
The second stage there.
I'm sorry to kind of labour it in such a
that's
slow
fine,
way.
because it's a very important part of, in fact, the pause, so it's absolutely topical to talk about it. So the second part of the procedure is then to set up a register, which will often be sponsored by the appropriate professional body, say the Pelvic Floor Society,
Yes.
for example. Now, that requires the patient's consent. You cannot set up a registry without the patient's consent under GDPR.
Yes.
But that is usually readily forthcoming, because why wouldn't they want to cooperate? But then there's also the problem of how to pay for it. And that's an issue. But if it is part of the introduction of a new technique, then it is sensible to make sure that takes place in places where they know what they're doing, by people who know what they're doing,
Yes.
and that they are resourced to run the registry, which then is a dynamic inquiry that goes on year in, year out,
Yeah.
and which will pick up both short-term and long-term problems, and can also, because it's linked through the NHS number with the patient's permission, it can link to MHRA or any other body. Does
Yes.
that make sense?
Yes. Yes. And I think that the funding in that particular sort of set of examples, you can think of ways in which that could be, I think, quite readily achieved, because we already have some examples of that. The National Joint Registry adds a small surcharge to every implant that is placed. So if it's a device or an implant that's being used, there would be a small surcharge. I think if it's a new technology, then I think you're right. You know, new technologies, if we were to take robotic surgery, which we do believe is likely to become more prevalent and more widely used, I do not think that it's appropriate that every hospital, every Tom, Dick and Harry should be, as it were, experimenting and learning how to do robotic surgery. There needs to be a commitment made by trusts with sufficient expertise and infrastructure to introduce the technology reasonably, and perhaps there could be some central funding that would be allocated to the designated centres, and the centres could compete. They could interview to see who should be awarded contracts to try and develop a certain type of technology. So I think each bit of the puzzle can be addressed. I'm not saying those are the only possible solutions either, but I mean, I don't think they're beyond the wit of man.
The principles of such a strategy you would support?
I would.
Thank you.
Can I just ask you, Professor, when we've been going around the country listening to patients and the problems that they've had with the insertion of mesh, and it's been horrendous, really horrendous. Can I just ask you though, because there is a suspicion that in some cases there's been a very active medical device industry that has actually had an influence on some of your colleagues to insert the mesh. Now, this has been put to us by patients. We don't have evidence of this, but I just wondered if that's an issue that ever comes across your desk, or anything that you feel should be done about it.
Well, I think it's a common issue that's raised. I mean, we see it in the press and we see it on TV, and I can't believe that it's entirely fictitious. I do believe that the majority of people who insert meshes do so with the patient's best intentions, etc. But we do know from recent history of the behaviour of some surgeons in other spheres that not everyone behaves honestly, and if there are financial inducements from independent companies and people who practice independently, then of course some people are tempted and will do things that are perhaps inappropriate. But we don't have any data on that either. We only know about the few people in the surgical profession who have been significant outliers in terms of their behaviour and the harm that they have done to patients. Patterson being the most obvious example in recent years.
So do you think there's something that should be done when we establish, we hope we'll be able to, these registries, that the conflicts of interest should be declared by the surgeons who are doing the operations, so that the patients can see it on the web or whatever, and they can see what support the surgeons are getting from the industry?
I think that is absolutely essential. The tragedy is that we have to do that in the first place.
Yeah. Can I just say, it happens to parliamentarians. So we all have to declare our interests, and it's reviewed every year.
Yes.
So people know exactly.
No, I think that the culture of transparency within the profession as a whole, not simply in surgery, still has some way to go. I think the surgeons are doing better than many other branches. We publish all our results from our NHS practice, at least. Nowadays, you can go on the internet and find out what a surgeon's results are like. So we do that, and I think the culture of openness is there in the profession as a whole. But of course, there's a difference between what people do voluntarily in their NHS practice and what people will do compulsorily.
So thinking about mesh implants, I mean, what has certainly come to our notice again through the patients and patient groups is that initially it might have worked very well, but over the years we've heard about how the mesh disintegrates. Sometimes it stretches, sometimes it contracts, sometimes it certainly moves around the body, that the mesh then encompasses other organs, so that actually to take the mesh out is as dangerous as it possibly could be. So I'm just wondering what we do. How do we ensure that the longer term outcomes are notified and that we learn from all that?
So I think there's two things here, of course. The reason that you have to have a compulsory registry at the start is so that you get an accurate denominator of the number of people who have meshes put in, and when you set the registry up and you decide on the information that you want to collect, you have to think very carefully, not just about, let's say, technical issues related to placement, so that's, you might say, intra-operative or peri-operative things that might work and not work. You then have to think about short-term complications. You might believe, in the context of, say, a mesh implant, that knowing what happens within 30 days is not really worthwhile, but knowing what happens, say, after 90 days might be a better short-term outcome, and I'm sure the experts could tell you what they feel would be best. And then, of course, you're right, you have to think, okay, are there possible long-term risks related to this device? Does the device last? Does it leach ions of a certain metal into the bloodstream, as we saw, for instance, with the metal on metal hip replacements? So people have to think very carefully about the types of information that could potentially be worthwhile. And of course, people will make mistakes. Something totally unexpected will happen. So no one is trying to suggest perfection, but we have to get the best minds to create the best registries that last for an appropriate length of time. The audits last for an appropriate length of time, so that the problems can be spotted before you have thousands of people affected by significant complications.
Well, thank you. And then my last question for the moment is really about how sometimes patients have said to us that they felt that the surgeons have been very dismissive of their worries that they've put to the surgeon. They haven't recognised really what has happened, as the woman feels certainly has happened to her body. And so how can we change some of that culture?
This is a very difficult question, and I'm not going to try and duck it in its entirety, but I think that the problem begins right at the initial consultation, and the rapport that has to then exist between a surgeon and the patient, an understanding on your part that you are going to allow me to do something very invasive to you. I will forget who you are when we meet in Waitrose in 10 years' time, but you will certainly not forget who I am because I did this to you. So I think we must move away right at the outset from that old-fashioned concept of you simply consent to what I tell you to do, and we enter into a more shared decision-making process in which I explain to you just about everything. In fact, everything that you decide that you want to know. So there's a bit of patient education here. Patients have to learn that that's how things should be in the future. The surgeon has to understand that a 2-minute consultation, I'll put you a mesh in, you'll be fine, is not acceptable anymore. I think there has to be far greater rapport at the outset between the surgeon and the patient. Only in that way, I think, will the surgical community, who perhaps, as you say, a small number of people may be dismissive of patients, only by having a bigger involvement at the outset, I think, will the surgeon then be more cognizant of what it is that is bothering the patient afterwards. So I don't think it's simply a case of saying to surgeons, you have to be a bit more responsive to the patient's complaints. That's fine. I could say that till the cows come home. I think you've got to start right at the beginning of the journey and get the patient and the surgeon to have a much better understanding.
Thank you very much. Yes, we had quite a robust discussion earlier on this subject, so I'm not going to go into it again. So Simon.
Yeah, I mean, what you just said touched on something I was going to raise about informed consent. So many of the women that we've spoken to and met feel that they weren't adequately warned about the incidence or the severity of mesh complications prior to the procedure being done.
Yeah.
And this raises issues around the risk-benefit balance, and it's not specifically on mesh. You may wish to comment more generally, but as far as mesh is concerned, how do you think the risk-benefit balance should be assessed when complications can be life-changing?
Well, there's lots of different things I would say are important here. Of course, there is a real need to have a very full understanding of what it is that patients really want out of a certain type of intervention, and what type of outcomes are meaningful for that patient related to that intervention. And I'm sure you've heard all day about patient-reported outcome measures and things that measure truly the health-related quality of life of that patient in relation to that specific type of intervention. And if you don't have such a measure at the outset, you will make the mistake that surgeons did for many years in many areas. There's what I believe as the surgeon that's important, which is usually the physical result of my intervention on you. You look great, and your feeling about what constitutes a reasonable quality of life. I didn't want you to make me live forever in this miserable state. I wanted to go down a pub with my mates and enjoy a drink, but I can't do that anymore. So I think that we have to work really hard on the development of high quality, specific patient-related outcome measures, things that properly measure the outcomes that the patients are interested in, not what the doctors think the patients might be interested in, which is the old-fashioned way of doing it. And of course, that's really what gets you into the shared decision-making process, as opposed to what we used to call informed consent. And the law, I think, is very clear on this. Montgomery is absolutely explicit. You must tell the patient about every material risk that patient might be concerned about. Well, you can only know what the patient's concerned about if you have a good measure of what it is that concerns the patients.
But
with new interventions, part of the issue is that you aren't necessarily aware of risks. They may sort of come out as things are put into practice. So how do we ensure that surgeons are as aware as they can be and sort of up to date with the latest risk information and are adequately conveying this?
It goes a bit of a $64,000 question. You can't predict every unknown risk, if you know what I mean.
Yeah, no.
You know, even experimental evidence may not disclose a significant risk when something goes into clinical practice.
Devices.
Yes. But I think that's the reason why when you set registries up at the very outset, you have to have appropriate expertise there in order to, as best as you humanly can, think of all the things that are reasonably likely potential risks. Particularly, you know, I mean, just to get back to your point, you can have something that's a very common risk or a common complication, but it's relatively trivial, or it may be short-lived, and it's not of any great long-standing importance, and it doesn't have a long-standing effect on quality of life. Or you can have a very rare but very severe complication, and many operations carry with them rare complications, but which are devastating should they occur. So if I take one of the things I used to do is gallbladder surgery, the risk of the surgeon damaging the bile duct may be 1 in 400 or 500 patients, but of course if you do it, it is absolutely life-changing for that patient. So, you know, a rare complication, if it's a severe enough one, should be discussed with patients. Some patients will say, well, if the risk is really small, I don't mind, you know, I'm happy to undergo that procedure on that basis. Another patient, the next patient in the door, will say, oh, you know, I'm scared now, I don't want the operation. They're not right or wrong, that's just the difference in people.
Do you think it's important that surgeons are honest about what they do not know?
Yes.
So in the case of mesh, for example,
yes,
there's a lack of clarity over the long-term effects of having mesh inside the human body,
yes,
polypropylene inside the human body,
yes,
for a lifetime, because it's designed to be there for a lifetime. And surgeons, presumably you'd agree, tell me, surgeons should be very clear that they just don't know what the lifetime impact might be.
Yes, I think that's absolutely correct. If patients, you know, at the outset when these meshes and tapes were first put in, they said, what are the results like after 20 years? People should have said, we don't know what the results are like after 20 years because no one's had one in for 20 years. And sometimes, of course, you can make, let's say, educated guesses based on analogies from other bits of the body with similar things, but you have to be very careful about doing that. I mean, there is a difference between implanting a piece of polypropylene, for instance, in the inside of someone where there are organs and things, and putting polypropylene in the body wall for, say, an inguinal hernia repair. You know, that we've been doing one of them for 30 years, and by and large, we know about the long-term results too. We know what happens to mesh over a long period of time in the body wall. We shouldn't make the assumption that mesh inside your abdomen functions and acts in exactly the same way and that its fate is identical, because that's not the case.
I recognise urology and urogynecology, not your own personal specialisms, but I'll ask you this question anyway. TBT and TOT, the tapes that we're talking about for
yes,
SUI, are, as we understand it, inserted completely blind. There's no use of a camera or any other imaging technology. Is there any other form of surgery where that happens? That's a bit of a difficult one to answer off the top of my head. I feel as if I ought to be saying to you, of course, but now that you put me on the spot and asked me to think of one.
I've been thinking about it for a week.
No help.
No.
Well, there we are.
Does that raise any concerns in your mind?
Not necessarily. You see, there are things that we do that you would call blind in certain situations where things are sort of acceptable, but I'm thinking of the time. I'm trying to think on my feet here of some appropriate examples. We do occasionally, for instance, in cancer patients, if we're trying to open up a blocked tube, you can't see the way through to the other end, but we do use image guidance to be sure that we've ended up where we think we've ended up, and there are risks in doing that. So I'm sort of out of my depth here, it's not my area of expertise. I've never ever seen a gynecologist insert one of these tapes or meshes, or a urologist do it. I haven't actually personally witnessed it.
Would it be a sensible conclusion to draw that the people who do a procedure such as this blind should be people who are very well experienced and who know what they're doing, and not just have a go types?
There's no place for have a go types anywhere anymore, so we'll park that one. I don't think that's acceptable at all to modern society or to the surgical profession. I think that people should have the opportunity to practice. I think, of course, in the very near future, the ability to simulate and carry out a simulation beforehand will be viewed as essential. I do not think that the surgeon in 10 years' time, I've written about this, will carry out their first operation on a human being, albeit under very careful instruction from a senior and experienced surgeon who you've watched do it, or you've done bits of things, and then he says, okay, now it's your turn. That's how I was trained, that's how we had to train. I don't believe in 10 years' time that will be the case. I don't think society will accept that, and I don't think that the training group of surgeons will accept that. I think that you will have to have practiced on some type of simulation system, some high fidelity model, and shown that you can do the procedure competently. The thing in the operating theatre is to learn the issues around judgment when things are slightly different, etc. I think that people will be expected to have undergone team training, rehearsal with the other people who will be there, because there'll be lots of technologies, robotics engineers, etc. So I think in 10 years' time, the way in which we train surgeons will be different. So the scenario that you imply, I think if it's still happening, and I hope it isn't, I don't think that it has any realistic chance of still being the norm in any way, shape or form 10 years from now.
That leads me to ask the question, which I think I've spoken to you before about, and that is, should surgeons be credentialed to do certain procedures, and should a register be kept, which the public can access?
I think that it's very difficult to credential broad areas of practice because there's so much to do, and the risks of variation become so great. I think that credentialing should take place in very restricted niche parts of surgery. So let me give you an example. Say in the world of urology, we were here, yes? You might say, well, should we have a credential in urology? Well, there's so much diversity. No surgeon actually does everything across that spectrum of disease any longer. So you could say, okay, well, should we credential in uro-oncology? But then I would say, well, all well and good, but there are some areas there that are highly complex. I do not think that every urological oncologist should be doing retroperitoneal lymph node dissections for young men with advanced testicular cancer. And I do not think that every uro-oncologist should be dealing with kidney cancer that's invading your vena cava when you have tumour all the way into your heart. These are very complex operations. We need a trivial number of centres in the United Kingdom to deliver these very complex services. I think you should credential the centres and the surgeons who work there.
Right.
So let's just return to this specific issue, mesh removal. You might credential that small number of centres and surgeons who should be doing this particular complex surgery.
And then you could maybe make sure that you incorporate the quality control through the annual reappraisal.
Absolutely so. Absolutely.
Good, that's very helpful, thank you.
Any questions? Anybody have any questions?
Yes, I have one question, if I may. HES coding.
Yes?
We talked earlier about new techniques, new procedures. It seems to me that HES coding is always sort of catching up after new procedures, and certainly in the area that we've been looking at, so
Yes.
ventral metarectopexy, but also trying to separate partial removals from full removals. The coding isn't right, we're getting it wrong, we don't have a sort of
Yes.
overview therefore of what's actually going on. How do we do this better, this catch-up, which seems to leave people in the lurch not knowing really what the overview of activity is?
We could be here all this time next year to talk about HES coding. I mean, the principle of HES coding is fine. I mean, I think the problem is that, you know, and the coders by and large do a great job, but, you know, it's just another part of our NHS that is creaking, and it's a struggle to try and do it. I would say at the outset, of course, you've got to try and create a series of quite specific codes that fit for the types of intervention that are being proposed, and you should create those codes obviously at the time that you think of creating your registry, and you have to, as the Cyril says, one of the things that culturally we need to do, of course, is to get surgeons to understand that documentation of what you've done with a new device, implant, new procedure is a fundamental part of the conduct of that procedure. It's not some optional extra that you can choose to do or not do, and that includes accurate coding. So I think that this onus falls on the individuals who are carrying out the intervention.
And that's about getting the coding right, because I'm saying it's a new procedure that hasn't got a code.
Well, I think
it's the catch-up bit. It's the HES coding takes a long time to sort of get a code for that procedure. So in some senses, for a while, procedures are happening with no overview of the activity because no one's coded, and I just don't know how that process should work better.
I don't have a specific answer to you. I think one of the things that I would say though is that whatever coding you have, even if it's a temporary form of coding, it has to apply across all sectors of healthcare, at least in this country. And that's every bit as important. So, you know, many new procedures and new devices and new technologies are offered in independent hospitals before they are offered in the NHS for financial reasons. And it's unacceptable for there to be two different systems of, let's call it, healthcare accountancy. And by that I mean everything that we've talked about so far.
May I just say that my question and suggestion in relation to the operation note would have to apply in the private sector just as it does, and it wouldn't be an optional extra.
No.
And indeed at the moment, and as I should declare the interest of the non-executive director of the Private Health Information Network, as set up by the Markets Authorisation Authority or whatever, does actually require the linking of private and NHS HES data. Can I just ask you something else to end with? one of the concerns that I felt as a doctor on this review is that it has taken the activities of individual patients forming into groups and then lobbying into Parliament and then being taken up by parliamentarians to actually bring to our attention the problems that they have experienced through both Primados, sodium valproate, and the insertion of surgical mesh. And I say to myself, why has that actually happened that way? Why have I, as a doctor, not got there before them? And do you have any observation on that?
I think that, well, I think it's very sad. So I'm sure you and I share the same sentiment there. I think one of the things is when I talk to my colleagues about events in the past that perhaps have not worked all that well. If I were to take breast implants as an example, my breast surgical colleagues tell me that they wished to have a registry, that they made approaches to parts of government about setting up registries in order that they should be able to carry out effective audits, and their overtures came to nothing. So I don't want to go backwards and blame people for things that didn't happen in the past. I'd far rather that we just cast those aside. But they do tell me that as a profession, you know, many professionals actually sought to have registries and audits in order to prove safety and efficacy for patients, and that financial constraints inhibited them from doing it.
Sorry, but if you look, if you go right back to 94, CERNIT, the safety and efficacy of new register
Yes.
new interventional procedures. Now that sounds like it should have, you know, been exactly what everyone needed, but it didn't happen.
Correct.
Well,
Why didn't it happen?
Yeah.
Well, I mean, I think we can go back into a myriad of causes about why it didn't happen at that time. And as I say, you can have a kind of fairly futile witch hunt to try and determine who do you think is largely to blame for this. And I don't think it will get us anywhere.
But we could do better in the future.
But we could certainly do better in the future. And compulsion, I'm afraid, is the only way forward for registries and audits. And I might say, at the end of the day, an organisation that will act as a regulator, and that would certainly not, to be absolutely clear about this, that would not be a Royal College. We might hold a registry. I would be very happy as a college to set standards for the level of performance of surgeons. But I do not believe that the same organisation can be the regulator, and there would have to be a separate funded regulatory body.
Yes, yes, I can understand the reasons behind
Yeah.
that. Can I thank you so much, Professor Alderson, for coming and for giving us such an interesting session. I really appreciate it.
My pleasure.
Thank you very much.
Thank you. Happy to do it.